Much of today's discussion is going to be on the Accountable Care Act, and essentially how we expanded Medicaid in the US via the private insurance market. So just in case folks are interested, the origins of the ACA was through a conservative think tank, the Heritage Foundation. And the concepts are efforts towards universal coverage, which is certainly ethically what we'd all like to see. It requires an individual mandate for an adequate risk pool. Remember the issues of insurance that you have to cover that 5 to 10% of people who are quite ill with the 80% of people who are entirely healthy, maybe another 10% in between. It actually, conservatives like to have minimal taxes. So there was an interesting mechanism of tax credits that would be based on income, reimbursed to the insurance company. So there would be a premium set by the insurance company and also with limitations. And if the patient could not afford that premium, which would be most of us, then there would be a IRS contribution directly back to the insurer, the health insurer, to make up the difference. And there would be a modicum minimum benefit package. This got deployed successfully for the time in Massachusetts, which is just south of where I live. And I have kids and grandkids in Massachusetts. So they've done a pretty good job in covering almost having 100% universal health insurance, building initially on what was called Romney Care back then. There are still problems, but nonetheless. Now, I don't know why I threw this slide in at one point. It just basically was when the ACA was being debated. And the reason I have this slide up is, as we'll see, there was an intense debate to prevent the passage of ACA. And up at the top, you'll see that Obamacare was a proposition. At the bottom, congratulations, you're insured. That line, those red marks through single payer to the right side of the graph is what happened as the legislation was making its way through Congress. So here is the Affordable Care Act passed in 2010. And that child on the side actually is a healthcare justice activist whose mom died of pulmonary hypertension, which is not always curable, but she was uninsured and she fell between the cracks. She was not eligible for Medicaid, so not uncommon. And John Dingell, who was standing behind Obama with this passage. What did this look like? What were the features of the ACA? Where's my, I want to minimize you guys, but oh well. So this was, the major feature was expanding Medicaid. So the eligibility in all states initially in the legislation was to be expanded from 100% to 137% of federal poverty level. So the initial legislation in 2010 made it mandatory for all states. Due to arcane constitutional reasons regarding federal taxation programs and the like, the 2012, the Supreme Court decided to say that no, this cannot be mandated for every state. It is actually optional for states to participate in this. So some of the initial benefits of the ACA were hobbled. And of course, many of the states currently, mostly concentrated in the South, did not embrace the ACA. The other element, as we were discussing, are what are called premium tax credits for low earners. And this is not just expansion of Medicaid. Now we have the use of the marketplace, the healthcare marketplace, which are private insurers who will apply to be a provider on a marketplace in a particular state. So if I live in New Hampshire, which did expand, accept ACA, we have probably 3 insurers, maybe Humana, Aetna, somebody else, United Healthcare, and they will set premiums that are regulated for folks, for all folks. It's open to everybody. But if you are earning between 138 and 400% of the federal poverty level, then you are eligible on a prorated income-based scale to get reimbursed for paying for that premium through the IRS, actually. So the private insurers get their full premium. They're not minimizing their premium. They're basing it on a variety of actuarial factors as well as previous experience, and there is some limitation on profit taking. So they base all of that premium tax credits are based on the silver plan. That's their benchmark plan. So there are buy-ins for other individuals in the community who do not necessarily have premium tax credits. And we talked about the insurance exchanges. The other important thing, I think most of you know this, that there was a lot of discussion over over mandates. So those of you who may have been able to read Uwe Reinhardt would see some nice charts and some, I think, worthwhile reading about the fact that individuals were mandated to purchase the ACA as part of the original legislation. Why were young individuals who may not have wanted to have insurance mandated, again, to have a risk pool that wouldn't go broke, to pay for the care of people who are requiring heart transplants or bone marrow transplants or their valve replacement, etc. However, it's going to be more expensive for those individuals. They could probably get cheaper insurance that doesn't cover things as comprehensively, but they need to be funding the overall kitty. This was deemed to be unacceptable to a lot of conservatives based on consumer perspectives of healthcare. And so it was repealed. It was not ruled unconstitutional, but in the Trump tax bill of 2017, part of the legislation was to repeal the individual mandate, which one would think would jeopardize the whole house of cards, but it actually doesn't, because the health insurers just raise their premiums to pay for more, in the absence of more funding coming into the kitty, to the pool, and they can. The employer mandate, however, remains in existence. That has not changed. By the way, if there's any questions, please give me a shout. So if you are hiring more than 25 people, I think it's 25 people, you're mandated to provide benefits under the ACA. Lastly, there are essential benefits. Unlike a lot of other insurance company policies, the ACA mandated if you are going to be providing health insurance throughout the US under a variety of different contexts, you need to be providing these essential benefits. As we'll see, that has also changed somewhat, and this legislation has been altered.
Question.
So, yes, please.
Um, so because that individual mandate was such a lightning rod, like people were upset about that thing. Um, is there any fear that people could have an actual successful legal challenge to getting a national health care plan, in that everyone would have to pay in? I mean, because we do have systems like the VA, which you are covered and that's your health care, but like, is there a concern that there might be a legitimate legal strategy that they may be able to get out of this?
It's a great question. And I think the short answer I would say is no, because that's one of the reasons why, well, there's a number of reasons why I think Medicare should be the avenue by things being expanded, because Medicaid, remember, is state funded.
Right.
It's 50% or very varying degrees of state funding versus federal funding. So there's huge variability from state to state. Medicare is a federal program that's fairly uniform. Every state must have Medicare if you're for folks who've earned it by just aging to be 65. So those deemed acceptable to have a federal health plan. It's funded through so much of the funding is through payroll taxes,
Mhm.
which is sort of, and it's the difference between the ACA and Medicare. Remember, there's no payroll taxes. We'll talk about funding shortly, but it's not a uniform, everybody pays into it, everybody gets something out of it kind of thing. This is really and geared towards coverage of folks in lower income. And so there's the mechanism for funding is very different. We're going to get to shortly. There is, if there were going to be constitutional challenges to Medicare, the bugs would have been worked out between 1965 and now. If does that make sense?
Yes, yes, yes.
So there is no, there really isn't a mandate from Medicare for me to buy Medicare. I don't need to have Medicare. I'd be stupid not to have it.
Mhm.
But at age 65, when I turned 65, I could say, no, I don't want to pay that $2,000 or $3,000 a year towards health insurance. I'm going to fly on my own. So I'm not mandated to have it. But if I'm still working, or if I've worked for the past 50 years or whatnot, all of my paychecks have already donated money towards it, if that makes sense.
Okay, okay. Yeah,
It's
that
like
does.
Social Security, and it is funded by the Social Security um, um, associate agency. Um, and so again, there's been enough time to know about constitutionality of these particular kinds of nets of safety nets for this country. Does that make sense? There's so
Yes, yes.
there's something unique about the accommodations that Obama had to make. He was very realistic. So let's talk about how this got passed. Um, Obama was realistic about what would possibly be passable in the Congress as he started his administration. As we see with a variety of folks in Congress today, even if you're a Democrat, there's not a uniformity of philosophy about a variety of matters. So, coming from the Heritage Foundation, which is a conservative think tank, coming from a conservative perspective, this was felt to be the best chance of passage since he was hoping it would be bipartisan.
Right.
Um,
Mhm.
this is, as we talked about the public option. Well, we may not have talked about this. How many of you guys heard about the public option during the last presidential primaries? Everybody was talking about it, right? So everybody was talking about the public option. Essentially, a public option is a government-sponsored health insurance which competes with the private health insurance for the same enrollees. All right. So it's actually government sponsored slash funded, um, but for that similar market. Over age 65, that wouldn't be the case, would be for those less than 65. So when the ACA was written, this was built into it by the House of Representatives. It passed the House in 2009, and then it went to Max Baucus's Senate Finance Committee for the Senate to work on the legislation. The world we live in, with the corporatization of our representatives and campaign financing, that is really a big issue. I don't think it was just whether it would pass or not. It was off the table that there would be a public option. Here's one of the ways that health insurance and the medical industry, the medical healthcare industry in the U.S. Is able to influence legislation. It was off the table. They did not allow any representatives from public option to be at the dais. There was a dais filled, I don't know, 20 people from from various walks of life, various insurance companies, hospitals, you name it, with folks who had various stakeholders. Nobody represented public option. That was done deliberately. So this allowed people less than age 65 to basically enroll in plans like Medicare or Medicaid. Private insurance knew that they could not compete successfully with that. What happened, by the way, if you're interested, I don't know if you want to watch this. It's basically in your slides. Do you want to take a break and take a look at this? It's up to you guys. Basically, this what am I talking about? There are folks from PNHP, from Physicians for National Health Program, who were planted throughout the audience in Max Baucus's Senate Campaign Finance Committee. I'm sorry, Finance Committee. Wish it was a campaign finance committee. And they would stand up periodically asking how come they weren't on the dais, talking about America's opinion about this, why wasn't it allowed? And it was sort of a, one of these insurgencies. They were all politely removed by police as they stood up. It's kind of entertaining, but you see one level of advocacy, which unfortunately is not always successful, certainly was not in this instance. Anyhow, what ultimately happened was the ACA. Does somebody want to read this? Sometimes it helps. Can somebody read the slide here? That may help get you guys in, I would say, not falling asleep. Who wants to volunteer?
I can read the slide.
Thank you.
So features of the ACA/Obamacare: no denial for pre-existing conditions and no limits on annual/maximum coverage amounts, coverage for children under 26 years, incentives for improved hospital safety and avoidable hospital readmits, incentives for coordinating care, limits on profits by insurers. Old cannot be charged more than 3 times what younger applicants charge. No public option allowed. Offered via insurance company in state exchanges. Insurers must provide 10 essential benefits.
Great. Thank you very much. And we're going to get to those as well. Thanks, Simran. So remember, I don't know if you remember from Wednesday, the world was really, an American public was up in arms against denial of claims by the managed care health insurers. There were people going broke because their pre-existing conditions were not getting covered. The children did not have coverage. A lot of what happened had to do with the climate of privatized healthcare in the US preceding this. This pre-existing conditions, which is now, fortunately, I think entrenched, that insurers can no longer deny on that basis. That's a big win for Americans' health. Anyhow, these are those 10 essential benefits. Somebody want to read this?
I just had a quick question.
Yes, please.
When we were talking about the public option, I understand obviously the private insurance companies wouldn't want competition in that way, but isn't there a chance when you're talking about like covered lives and lives that are riskier to cover, if there was a public option, people who had chronic health conditions or had less money, lots of different things would go towards that public option, and then private would, benefit in some ways? Like, I guess I'm confused why they were totally against it.
Absolutely. So it's really, thank you. That's a terrific question. And I didn't throw it in here. I think we may tackle that hopefully in another stage. What you just pointed out was what's actually happening currently in Medicare with what's called Medicare Advantage versus traditional Medicare. So what Jace mentioned was insurers are pretty smart. They've been doing this for a while now. They know how to underwrite insurance and recruit enrollees. So if a public option were offered, this may be for folks, it would be very nice to get an inexpensive policy from Medicare rather than paying the big bucks through a private insurer. Why would a private insurer not want to take those people? For obvious reasons, they're too expensive. How would they lemon drop such people? So let's say all of a sudden you're required that the marketplaces as they exist now, all of a sudden we pass the public option. So right now they're covering a lot of people who have expensive medical issues. If they now have a public option that they could basically shift that medical loss off to taxpayers in a different way. By the way, we're already paying for their premiums with tax incentives or tax drops. But if they could shift those patients, they would do it by making the formularies eliminate medicines for complicated medical problems. If somebody has heart failure and they need Entresto, or they see that they're taking torsemide or furosemide, that's going to signal something in their computer system to make it more difficult to get the associated medications for heart failure, for instance. Okay, so when the patient goes to purchase their medicines, it's tier 4. What do you mean tier 4? I'm paying for all my medicines. Sorry, that's how we rate it. So they can't afford their meds. They're going to go over to the private to the public option. That point about lemon dropping is what's going on currently to an extent. I think there's pros and cons of Medicare Advantage. I don't think it's all a downside. I for philosophical reasons, I have traditional Medicare. I didn't want to go to the dark side with the Medicare Advantage, but it's exactly the same process. And as we'll see, it's also very expensive for our country to allow the private insurers to do that. So totally on target. Very, very. Everybody get that point about lemon dropping and shifting folks to the okay. Actually, I'm not going to. So just in terms of the essential benefits, most, if not all, ambulatory services, emergency services, hospitalization and surgeons and surgery, pregnancy, maternity, and newborn care. Remember that conversation I had with the person selling me their insurance on the healthcare marketplace? It costs you so much because you're having to cover somebody's maternity care. Yeah, well, that person might happen to be my sister or my wife, but it's certainly not me as a male. But so that is built in. Every insurance has to cover that. Mental health and substance abuse services, although that's changing to have increased coverage. Prescription drugs, rehab services, lab services, colonoscopies, mammographies, CT of lungs. That's a big ticket item. Low X-ray CT scanning for screening for lung cancer, Pap smears, abdominal aortic aneurysm screening, etc. That's built in. All pediatric services, which includes pediatric dental care and vision care in adults, that is not part of it. I think the American Dental Association might have been involved in that as well. Do people remember when, well, that was back in 2012. I don't know how old many of you guys were, but there was a debacle when the ACA got distributed, when the website was open. Does anybody remember that? People were trying to sign on to the ACA and the site crashed and nobody could get on it. It was just a debacle. It was just a shit show. They finally worked out the bugs. It took a year or two for it to happen. And again, it's so interesting. When there is incentive by government for something to happen, it's going to happen. And I don't think it's just because of the complexity of of websites. So just for comparison, Medicare with their old software on paper enrolled 19 million seniors within 11 months. So I think, there's stuff underneath the surface in terms of how things get deployed. That was when it, anyhow. So what, after the legislation finally got passed, what was its biggest effect? It helped Americans primarily through the expansion of Medicaid that was built into the legislation. So prior to that, it was based on a federal poverty level. State by state had various qualifications based on whether you're disabled, based on the size of your household, based on whether you have children, based on whether you're seeking work or not, whether you're taking care of other people in your household. Every state was different when it came to traditional Medicaid. If the state decided to accept the ACA, there was a simple qualifier. All the rest was eliminated, which was basically income. If income was below 138% of federal poverty level, you qualified for Medicaid in that state. So that was just basically raising the income qualification and some more uniform aspects. We talked about the premium tax credits, which is available to people between 100 and 400% of federal poverty level. That's a big deal. That's also incorporates a lot of low-wage earners, a lot of folks who are not that well off, who now have additional benefit to afford premiums. And prior to that, they would not be working typically with a large employer. And if they did not have insurance. So this was a major issue. That did make a difference. Adults in states without ACA expansion. There is a gap of, it's actually about 2.3 million according to Kaiser Family Foundation. There are those folks who don't qualify for Medicaid because of some of those other issues. If you come from a state that did not accept the ACA, they could still exclude people from Medicaid based on disability or lack thereof, or whether you're not working or haven't sought employment, or a variety of other factors. So there are folks who are making less than 100% of federal poverty level, but don't qualify for Medicaid, but they also don't qualify for the premium tax credits because they're not over the amount. They're sort of stuck in the middle. And so there's about 2.3 million people who don't have insurance on that basis, which is kind of wacky. So did the ACA work? Yeah. It dropped the number of folks who are uninsured. And I like this chart. So this is a timeline. Joey or Jason, I don't think, is there a way that I can get a, I've lost my cursor. Curse this cursor. I cannot find it. So I don't know if there's a way that I could get a, to put something on screen like a laser pointer. But anyway, not to worry. You guys will get.
You got me stumped on that one. I don't know.
You'll get your certificate of expertise from Zoom at the end of the course. But right now, so just to look at the middle of the chart, the individual mandate took place I'm sorry, the ACA was signed into law back in 2010. The exchanges is what I wanted to show. Opened in 2013, pretty much as the rest of it was getting deployed. And so as you see, Medicaid was ultimately expanded in many of the states. There's a pretty substantial drop in percentage of unemployed. In subsequent years, between 2016 and now, initially, there are more people who became uninsured once again due to the ability not to have the mandate, that's part of it, but also due to other phenomena such as the ability to go to be eligible for a skinny plan, and of course the pandemic, which resulted in people losing a lot of their employee-sponsored insurance and just did not enroll in the ACA. You know, it's driving me nuts. I'm gonna just, there's my cursor. Okay. Let's go back to, all right. So how is the ACA financed? Who pays for it? We talked about some of the enrollees used to be able to pay for it. I'm sorry, it's not 25, it's 50 employees. I couldn't remember for sure. You need to employ 50 people to be mandated to offer ACA coverage. There used to be a penalty on individuals, no longer. There remains a penalty on businesses who do not purchase this insurance for their employees. So how is it funded? There's various weird gizmos, none of which includes payroll taxes. So it's really a tax on capital gains and dividends, some of these mechanisms that well-off people have. There's a tax on what are called Cadillac health insurance programs that was actually repealed in the 2017 tax law. There is a slight increase in tax rate, not via the employer, but just in terms of the tax for on income. There is a fee for big pharma and health insurance. However, the excise tax on sales of medical devices and I believe the cap on tax deductions for CEO pay all of it was eliminated also in the 2017 Trump tax law. So again, you're hobbling some of the financing, which is going to result in premiums going up.
One question.
So, yes, please.
What do you mean an excise tax on medical devices? Like people
Yeah.
who get a hip replacement are paying more taxes on the hip replacement itself?
No. So the tax is on the manufacturer.
Okay.
So remember that chart we had of what goes into a hip joint, you know, the prosthetic hip joint?
Mhm.
You know, there's like 20% research and development, 40% marketing and advertising, another 20% that did not go into anything useful, but was sort of profit, and sort of the people who are going out to sell the products as well, but just under another category. And then you had maybe 20% of the actual cost of manufacturing. So that of that pie chart, there's a lot of stuff that does not go into the cost of the actual manufacturer, that goes towards profit, essentially. So that excise tax is on the Medtronics that makes the pacemaker,
Okay.
or the product, or the stent maker. So some of it actually goes to fund this, because does that make sense? Other questions? So it doesn't go to the consumer, and that's an important issue for sure. Okay, so does anybody here have Obamacare? Have anybody covered under the ACA? Anybody ever apply for the ACA?
I
Great.
applied.
What's
I've
that?
helped people apply.
Well, I'm sorry. So for folks who, if you don't mind, I'd be interested in your experience, Wong and Shino, and whoever else might have had ACA or applied for the ACA.
Yeah, I went to the market a couple years back, and I don't remember the specifics, but I remember it was just way too expensive for me. And I'm not like I don't even think I'm a middle income earner. No, at the time, it was just way too expensive, so I just went without.
Yeah. Do you remember? And this was a couple of years ago. Do you remember? So remember, it's as a single person, 400% FPL. Did you have to talk with a salesperson when you were in the process, or were you doing it mostly online?
I did it online.
Great. Did everybody see? There's I think I have it in a later slide. Oh, it's in one of my notes. Kaiser Family Foundation has a calculator. It's in your notes. It's in some of your links. And you could pull it up to see if you're eligible for those premium tax credits, okay? Many young people are not, which is why a lot of young people did not have, you know, you'd have to pay an increased amount of taxes per year if you decided not to get health insurance. That's what the mandate was all about. It would often be, you know, less costly. I don't want to deal with this. I'm just going to pay my tax penalty rather than pay into an insurance that I don't think I need. And again, why was it so expensive for you? Because you are paying for everybody else when there's underfunding. Does that make sense? Or the people who really need to care. Shino, had you tried to get the, what was your experience?
I did. So when I was between my my last undergrad and coming into year one of medical school, I worked at restaurants mainly, so I didn't have an employer option for insurance. So I did apply for Obamacare, and I was awarded the Obamacare as well. And so I don't remember exactly, like I didn't understand everything at the time. So I had it, and then I guess something else went into effect at some point, maybe 2018 or so. And so before I wasn't paying anything. And then at some point I was paying like $15 copay. So I don't know what the shift was in terms of what acts and what laws were enacted, but I was able to get it, and it wasn't the best. My primary care options were very limited. Even though I didn't have a good rapport with mine, like she didn't listen to me, she just did what she wanted. I had to keep her because there wasn't anybody that was taking new patients or taking Obamacare. And so I just had to put up with that for several years.
And thank you. And really some interesting insights. By the way, it so so your comment was you're sort of locked into a provider who you may not have been that happy with. So that determination, that whole issue came up. Can you keep your doctor? I don't know if people remember that conversation. Can you keep your doctor? Definitely. And turns out to be not so true. So what was the limiting factor there? Why couldn't you keep the doctor who you had? Remember, the marketplace is private insurers who are managed care organizations. They're essentially complicated HMO. They're HMOs, health maintenance organizations, who make a profit, who are able to maintain costs by having a number of doctors they contract with. All right. So you've got 3 insurers on the healthcare marketplace in the state that you're from. Each one of those insurers is the private insurance company that is being reimbursed by ACA, have their own cadre of physicians who they contract with, right? So if you switch to a different insurer under that healthcare marketplace, there's no guarantee that they would cover other doctors. As you said, not all doctors necessarily wanted to have that insurance that they would be using, depending on their reimbursement. So that's a real issue with pretty much any of these programs except traditional Medicare, by the way. That's what's built in, and that doesn't benefit necessarily us as consumers. It benefits the insurer. But thank you for both of those insights.
I've got one more thing that I forgot to add. So with Obamacare, or while I was under Obamacare, I had one of my ACL injuries, and so basically I went to an orthopedic doctor, and they told me that, rest it, ice it, the RICE method, do that, and then come back in 6 weeks or something, and then we'll reassess. So basically, they wouldn't allow me to get an MRI, even though I basically knew that I had torn my ACL. But they wouldn't listen to me once again. Mm-hmm. And so then I had to wait another year until I was employed somewhere else where I was able to get hospital insurance in order to get even to get a proper diagnosis and then get my surgery done. So that's an issue with that as well.
Thank you.
I wanted to chime in also. I was helping, this is Shivani speaking, but I was helping people get healthcare in Maryland at the time, volunteering in some capacity. And I found it was just so sad that some of the people working at organizations did not qualify for any kind of healthcare, but the people they were helping did. And it was just weird. It was a really strange dynamic, but also kind of echoing what others have said. It was only until like certain of the clients and patients really could get fully Medicaid-based insurance, they got much better treatment, many more benefits than they did ever on a market exchange plan.
Interesting.
I thought it was interesting.
Yeah. So very interesting. So, what we're talking a little bit about is profit. If your mission is to make a profit, that is why you're the CEO. You will everything will go downstream in terms of the culture of that corporation. If you're being traded on Wall Street, if your job is to show improving profit from year to year, you'll do what you need to do to make that happen. So a lot of countries use intermediary health insurers. As you do some studying about this, an intermediary health insurer is not necessarily the problem. It's how they're regulated and how they meet the needs of healthcare. So we'll talk about that further, but thank you that's really helpful insight, Shivani. And for those of you who did have the ACA, remember, there's also deductibles. And that does vary based on your income, but you can afford your insurance, but you may not be able to afford the care you need to get before the insurance kicks in. And we're going to talk about that. So thank you. This is all very valuable. So again, just briefly, the various tiers of what's offered on the marketplace. Lower premium plans have the enrollee subjected to higher out-of-pocket costs. So you pay less for the premium, but you're going to have more deductibles and more copays and whatnot. Again, under 2017, catastrophic plans got reintroduced. So they basically will cover, you know, hospitalization after a motor vehicle accident or after a myocardial infarction, but only if you get to a certain number of dollars of care. And folks who are eligible for that were young people. I'm not entirely sure about all the hardship exemptions, but those have, of course, huge deductibles. So here's an example. The other thing that the ACA introduced, by the way, was caps on how much somebody would have to pay in deductibles and copays. So as I mentioned, it was income-based. So the lower your income, the less you'd have to pay of the percentage of your annual income. So if you made between 100 and 133% of federal poverty level as income, you had a cap of 2% of your yearly income, which would translate, I don't know, to, I don't know, $600 at most or something like that, probably more than, probably less than that. The higher your income level was, the higher percentage of your income would be going towards healthcare, but at least there was a cap. And just to sort of illustrate that, this is, you'll find this on Kaiser Family Foundation, and I think I have a site for that. So if you're, this is an example of Pat. She's 30 years of age. She is at 250% of what's considered poverty level. She is, everything is benchmarked to the silver plan. So what's available to her in the marketplace would cost her $500 per month. That would be the premium. She would have a cap of 8.3% of her income for that silver plan. So she would not have to pay more than $220 per month. That's based on that cap. The tax, so what if it costs $500 per month, the IRS would be paying the insurer $279 per month to make up for the difference. So if you guys get a chance to read today's article that I slacked to you by McCardle, I think what she said, there's a lot of fair and true statements. One of the things she said was that it didn't make much impact on bankruptcies in the United States. Actually, so let's now talk about the effects of the ACA. It did have a decline by about half. So if you look at 2010 and 2017, you'll see that the incidence of bankruptcies dropped by about half. That's not trivial. How did families manage with their financial bills? This is from Consumer Reports, as taken from the HHS and Centers for and CDC. Actually, if you were a family, and this is based on both individuals as well as families, did you have a hardship in paying for medical bills in the previous year? The number of folks who said they were facing serious medical debt also dropped. A different way of looking at the same issue. So I think the impact for lower income folks was substantial, but not as great as it could be for a lot of complexity reasons. What time is it? We have gotten, so I'm thinking about your butts and my bottom. It's been an hour. Wow, that's a long time. Do folks want to take a bio break? Yeah, yeah, there's okay. Let's take a bio break. Come back in 5 minutes, or let's say come back at 10:05. All right. Do people want to do some go into breakout rooms to tackle the issue of the ACA, or want to push on after that? Don't all speak at once. Caitlin, you're smiling. What are you thinking?
I mean, I always like a good breakout room, but if there's a lot of material to cover still, we can. I mean, I'm good with whatever.
We definitely want to have time for the next speaker to come on. So, I think given the morning schedule, let's push through the didactics and then have a breakout room to fill the time until the next speaker comes on with it, which is about advocacy and use of media. So I don't want to intrude on that. Okay. So we'll meet back at 10:05 if that, okay. You just told me what you thought. I just basically told you, never mind. I just said, forget that. We're talking about the passage of the ACA, which did come to pass. Can everybody see this? So I don't know if folks remember the town hall meetings after the ACA got passed. Wow, was there organized? It was organized, but as many things are, reaction to this. So of course, I love this slide because it says, keep government out of my Medicare, which is basically Medicare is a government funded system. You damn socialists, I love it. But this came up with the ACA. We'll talk a little bit about how socialist the ACA really was. But so that was really a really compelling period that I remember. It was in the press. Then came the 2012 election. And I don't know if you know this, but Romney ran against the ACA. So I love it. So and yeah, and he instituted it and made it work in Massachusetts. So I love this cartoon, this political cartoon. Your kid is ugly. Was this a socialist endeavor? Well, I don't think the insurance companies thought it was. So here is the experience of the insurance companies under the ACA. Remember, they're charging premiums that they're getting paid by the taxpayer to support for those who cannot afford it themselves. So if you look between 2014 and 2017, really after the ACA got started, look at the upward profit spiral. Cigna, Humana, all of them did pretty well in terms of profit. And again, of course, with the pandemic that we've just seen, when they're not having to pay out any costs because nobody's going to see the health their doctor, obviously profits skyrocketed again. While they're making that profit, the annual premiums for on average for Americans is skyrocketing. So they're making profit. They're making profit as they're getting paid more year per year to deploy their insurance. So look at the difference between 1999 at the top. That's a family coverage of $5,800 per year, and family coverage in 2017, which is now almost $19,000. It's wild. Single coverage goes up in a similar fashion. Somebody's making a lot of bucks, or we're spending a lot more on healthcare when we weren't spending that much. We were talking about socialist experiences. Well, I guess from that point of view, maybe that's true. That the free market is doing what it does, makes lots of profit. But in terms of how we all afford, it's a different matter. So this is from, as many of these are from Kaiser Family. So if you look at the scale, on the same scale of growth per enrollee in terms of how much they're paying for premiums, deductibles, co-pays, what they're paying entirely, not just the cost of premiums, goes up 53% between 2008 and 2018. Not like Medicare was controlling costs entirely. Remember, some of that Medicare is also Medicare Advantage. Medicaid, ironically, has done the best job during that period in terms of, because they have to. Remember, it's the price, stupid, as Yuan Reinhardt would say. Here's just something that we talked about the other day. If you looked at the number of scans done per country, I think this is a little bit, I should have put the other slide in here too. The US does not order the most number of MRIs nation to nation, or most number of procedures or interventions. Germany, in this case, France, Switzerland are pretty similar, but we're charging 4 times as much. So somehow there's a lack of of measures here. I had this slide. I think it's so who's currently left out among those 10 now going up to 20 million Americans, those who are not eligible in those states where they're not eligible, not poor enough, not old enough, folks in the gig economy, again, who are not poor enough or old enough, those who really can't embark on going through the system to engage in this, to be to get insurance, even though they may be eligible. Folks who are not getting care because of high deductibles, certainly undocumented immigrants without doubt, but also seniors who require long-term care. So there's a lot of folks who are currently not getting advantages from what we have in place currently, or not getting care. Again, did the ACA meet some needs? Yep. We saw some slides earlier about this. This is from Ed Weisbart. I like his slide. You're gonna many of his slides. Again, number of adults reporting that they had unmet healthcare needs, just in general. Not even asking them, why do you have unmet healthcare needs? Dropping from 46% back in 2013 to 13%. If you asked, and then again, comparing that to 2017, I think the pandemic, with some of the legislation that was passed over the past year, I think that's not dramatically worse, but it is worse. Other improved outcomes. This was sort of one of the earlier, because my slide is a little earlier, but I think it's kind of interesting. It's looking at how does having enrollment, remember that comment? I remember the guy's name was Labrador, the guy from Idaho who said nobody died because of absence of healthcare, from that first slide when we were talking about Martin Luther King and other people. It was Raul Labrador. So he would say, oh, I don't believe this. But bottom line, health outcomes, when you expand insurance and people can afford it and it's available to them, they do better. I mean, there's no doubt there. This is one of the earlier things, looking at cardiac arrest, which is kind of interesting. I mean, there's a dramatic event of cardiac arrest. So they looked at which states expanded the ACA, which states did not, and looked at the incidence of cardiac arrest. And there's a significant difference, 0.013 p-value between those states where it was expanded and those states that didn't, with that dramatic event. There have been 1,000 studies thereafter in terms of improvement in outcome. Did we limit administrative costs? No. It wasn't built to do that. And so because the private insurance companies are there in the healthcare marketplace, each with their own banks of utilization review nurses, et cetera, this is actually Himmelstein and Wohlhandler who did this analysis. So there is no drop. And so they have a bias. They are part of PNHP, but I think there are many other studies showing the same in terms of overhead. So we're going to not entirely leave the ACA, but talk about Trumpcare that's come and gone, because this is sort of a historical review. So when Trump got elected, he was talking about, well, if we can only make Britain look like America, wouldn't that be perfect? And a lot of Brits said, no, that would not be perfect. And basically their sentiment was what they have here. A lot of people love the healthcare that they have. We love a lot of things about America. Part of it is familiarity. Part of it is what we know, but part of it is also what's working for us. With the limitations that there might be, if you have to wait longer to get your cataracts, which you do in Britain, your vision's not going to be improved as quickly there as it might be here. Still, folks want to keep your hands off our National Health Service. So in terms of one of the earlier, I'm going to go over this quickly because it came and went and is no longer relevant. The GrahamCassidy Reconciliation, which got dropped. I don't know, do people remember John McCain and his thumbs down, that was in your generation, so great. So this was what was being proposed before that single vote that made the difference between abolishing the ACA and instituting basically crazy stuff. That bill would have repealed Medicaid expansion, repealed the subsidies from out of pocket, repealed tax credits, revealed all the mandates. It would have kept, which I guess they figured was popular and not that expensive. They would have kept coverage for folks until age 26. And basically, it would have brought back the pools of high risk tax pools which didn't cover anyone because of exclusions. It would have changed essential healthcare benefits and changed the process of pre-existing conditions. That would have not been met well, by the way. So anyhow, that was defeated, fortunately. How has the ACA been hobbled? Well, we talked about the initial legislation of the ACA. The initial law wrote that the federal government can withhold Medicaid reimbursement and health and sharing of dollars if a state didn't implement Medicaid expansion. The way that this was written, in the absence of universal tax requirements on every citizen, they said this was unconstitutional, coercive, and so it became obviously voluntary, which really hurt a lot of folks in those states. As we discussed, a repeal of the individual mandate, repeal of subsidies to an extent to some lower wage earners, and the reinstitution of some skinny plans for essentially catastrophic insurance. I think this is a similar slide. Oh, birth control, another issue. So it allowed employers to deny, and again, that may have other religious, I think we've seen just as of yesterday. Oh, I forgot to mention, did everybody read the news about the Supreme Court's ruling yesterday on the ACA? Yeah. So basically, the previous threat to the ACA, instituted by a lot of the states that did not expand the ACA, has now gone under the boards. I think the ACA is not going to have any further constitutional threats. But interestingly, what we did see was the Supreme Court is sort of prioritizing religious freedom and religious sentiment and decision-making over healthcare issues, and which may be good or bad depending on your perspective. But certainly there was a dent for those needing contraception that was added to the ACA's legislation. Oh, you might not know this. I was very aware of it. It was really remarkable. The funding for the ACA website, what gave people education about enrolling in the ACA, this drove me nuts. It was written into law. When the ACA was written, there was a certain amount of funding on a yearly basis that went into maintaining that website so people could learn about it and enroll. That got defunded during the past 4 years. It was pretty striking. And so people were not getting the information they needed. Despite that, enrollment dropped only a modest amount rather than a huge amount. So there's other, public charge rule. No, there is valuable stuff on this slide, which was if you were here on a green card, you were here legally, you were working, you were paying taxes, but you are not a full citizen. There was a public charge rule that was being instituted state by state that if you're taking the ACA and therefore we're funding part of your health insurance, we will look at that, and that'll apply to whether you can apply for citizenship, or it'll impact immigration, your likelihood of being given immigration for the long term. It's nuts. So really punitive kinds of legislation. I like this slide. Yes, please.
Just speaking towards a repeal of the subsidies to insurers with the subsequent higher premiums, as well as the skinny plans a little bit.
So the repeal of subsidies to the insurers overall has not come to pass. That would decimate the ACA. So that was one of the efforts to hobble the ACA. It is still law that if you are in that 137 to 400% of federal poverty level, you're getting you meet criteria to get some kind of subsidy. There was all sorts of legislation trying to hinder that. That didn't come to pass. So that's the first thing. So that was, but it was a threat. What was the second question you asked?
But yeah, because it was on the slide where a bunch of things did pass. So I was confused, but also reintroduction of the allowance for the skinny plans. I guess like lean all the
Yes.
offerings.
Right. So what did happen under that was an executive, I think it was an executive, I don't remember if it was under the tax law of 2017 or an executive action. But they were able to reintroduce plans that did not meet all of those ACA requirements. That is, there were people, you have to be under age 30, who could now apply for catastrophic insurance, which essentially, it's not even a deductible. It's you pay for your health care until you reach catastrophic levels of care needed in terms of dollars. So that was allowed to be re-implemented. Basically what we used to call junk insurance. I've had, back in the bad old days, I had plenty of patients who had junk insurance. They had serious scleroderma, short bowel syndrome, or other, various terrible disorders that I thought, they told me they had insurance. That's how I learned about underinsurance. I thought their insurance would cover this since they had healthcare insurance. Little did I know that it would cover nothing. So the re-implementation of that kind of junk insurance, I think it's now being repealed. I haven't kept up as well as I should as to whether some executive actions have now repealed that. I don't know. I don't think so. But good questions. And maybe as to the subsidies, I don't think that came to pass. I don't think the insurance companies allowed it to come to pass because they're making the big bucks from us for those subsidies. Does that make sense?
Yeah, that's why I was confused. It's like it didn't. I
I
don't think it pass.
no, it didn't. And I think it was a confusing slide. Thank you. I'll fix that slide. So I like this slide. I don't know if anybody. As you all know, this is which states expanded the ACA. Oklahoma, Kansas, they are now going to. Oklahoma's already implemented it. It hasn't been deployed yet. This is an old slide. I have a newer slide than this. I think Kansas also just approved it, but it hasn't been implemented yet. So basically, this is what things look like currently, except for those two states. And this is just talking about the administrative costs. I'm not going to get into the details of this because I do want to have some time to do other things. Just a reminder, I guess, that where the ACA, I think it's made a dramatic difference in the state where I practice. In New Hampshire, where I've practiced for many years, now I'm practicing in Vermont as well, but in New Hampshire, I've seen the expansion of the ACA make a difference in people's qualities of life and their insurance. It's anecdotal, but I see enough patients in the nature of the work that I do. I think it's made a dramatic difference. I think there's just a dramatic number of people who still are not applying for it and don't realize they're eligible for it, but I think it's made a difference. Having said that, when it comes to mortality, life expectancy, people are aware that there's been a huge dip in life expectancy. In the past 20 years, really more in white males, typically in Rust Belt communities, related to alcoholic liver disease, the expansion of opioid addiction into such communities, and suicides. And so this has been really a dramatic epidemiological experience that we've seen. I would share with you, and so in terms of how any insurance makes impact into the social determinants of health, that's a shortcoming of much of what we do in the US, and we'll talk about how that's different elsewhere. So low-tech measures of support, prevention, access, and engagement with a built-in engagement with the health and healthcare systems are critical to have impact on the trajectory of a newborn, the health of a new young mother. I guess the slide that I wanted to show was, darn it, sorry, folks. This is the slide I wanted to show, which I think was taken by Rural Access Medicine. For those states that have not expanded Medicaid, and I don't know, have any of you guys worked for Rural Access Medicine or worked in a clinic to help provide?
I have, yeah. It was in Appalachian.
Can you tell me about that? Can you share that experience with us?
For me, I was actually helping volunteer more on the dental side at the time, but it was actually just horrible to see with like the teeth getting completely messed up. I mean, dental coverage is so lacking anyway, but a lot of them were addicted to opioids and had, I mean, we're gonna end up with like cardiac conditions, and so many people were just giving their time to really help provide care where they're isolated, where they don't have a lot of other options, and maybe this is like a once a year thing for them.
Sure. Thank you. And how did people line up for it or enroll to were you working out of an office? Were you working out of a tent? What was the situation?
It was like a lot of tents set up in fields. It was like kind of had like a, I don't know, old time like war hangar kind of feel to it, like warehouse out in the field.
Mm-hmm. Yeah. So when you hear Shivani talking about people in long lines outside of a tent or a hangar or a Quonset hut, what comes to mind? From our slides that you may not remember, I wouldn't ask you to remember all the slides, but think reaching back into American history. What does that remind you of? Any-
I guess it reminds me of like the disparities and the lining up for vouchers. Like I'm thinking of more racial disparities, but I don't know.
There's that. You know so what the heck is this guy thinking? Let me ask you what I'm thinking. I was thinking of those black and white images of the Great Depression, of people on soup lines, on people lining up for miles just to get essentials to survive. Here you've got people, and so rural access medicine is dealing with this, and still in those states that have not expanded the ACA, people lining up for their hypertensive care, people lining up to get drugs for their diabetes that they can't afford. This is essentially a developing country. For any of you who have practiced overseas and done some volunteer work in developing countries, doctors come out to these places, open up a tent, and take out 1,000 goiters while they're there, or do 100 cataracts or whatnot. It's primitive care. It's obviously immoral and unjust on so many levels. This is still America, and so we've got some work to do. We haven't solved all these problems.